Today we will discuss GCS in a ventilated patients. I am Dr. Neeraj. If a ventilated patient is documented as having a GCS of say 3 by 15, everybody panics because it is a very low GCS score. Actually, it's an error because you cannot assign a full GCS score to an intubated patient because in doing so it leads to gross clinical misinterpretation. Glasgow Coma Scale has got 3 components: the eye component, the verbal component and the motor component. And in intubated patients having endotracheal tube through the vocal cord, you cannot assess the verbal response. So forcing a total GCS score artificially lowers the score tremendously, giving a false impression that the brain injury or whatever it is severe. Also remember, sedation, hypoxia, metabolic factors can suppress the motor response, further distorting the neurological assessment. So modern neurocritical care usually recommends reporting GCS in the format of separate reporting for EM and when the patient is intubated as VT. So instead of a total score, it will be written as E3, M5 and VT, not as a GCS of 8. Motor response correlates best with the outcome, and the total GCS is less reliable in intubated patients or sedated patients. Suppose a patient is on E1, M1 and VT and is on midazolam and fentanyl. This is a drug-induced coma, not a structural brain injury. Misinterpreting this can lead on to unnecessary CT scans, wrong prognostication and even premature withdrawal decisions. So always interpret GCS in a ventilated patient with the clinical context. First ask what is the sedation level, the RAS level, then assess the pupils, motor response and brainstem reflex. So if unsure, perform a sedation hold before neurological assessment for a better neurological assessment. So in ICU neurology, never score what you cannot assess. Interpret what is real and in front of you. Thank you.